If we have somebody breathe 100% oxygen for just a minute or two, we can change the composition of air in their alveoli from 21% oxygen to 100% oxygen. That means there's 5 times more oxygen available there. And that means that even when somebody is apneic, RBCs that are going through the capillaries in the lungs are going to continue to pick up oxygen. Your typical person can hold their breath for about 60 to 90 seconds. If somebody is breathing 100% oxygen, they can hold their breath for more like 5 minutes. And the world record for somebody breathing oxygen, 14 minutes. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Nick Mark, here as per my usual with Dr. Cyrus Askin. Cyrus, how are you doing today, man?
Nick, I'm doing well. I'm staying busy personally and professionally. We've got a few interesting cases that we're working through at my shop, and in my spare time, I've taken up woodworking as another means to channel what little creativity I possess into something durable.
That's awesome. That's another definition of shop. What have you crafted so far?
Well, so I should say that I've been operating under the watchful eye of my dear friend who's a CRNA here with me, who's been sort of like guiding me as I've been learning this craft, very much in like a ghost sort of sense, if you've seen that movie from way back when. But yeah, so I'm working on a couple cutting boards. I've got one that's just about done. The other one should be done here in the next couple days. And then there's my magnum opus, which is going to be a wooden Settlers of Catan board.
That's awesome. Though I do kind of feel like you should make your Catan board out of something like stone or clay, because those resources are obviously more valuable than wood.
Yeah, I mean, yeah, maybe sprinkle in some wheat.
Just whatever you do, do not make it out of sheep. Nobody wants to see that.
Duly noted. I think, before we lose the rest of our growing audience to bad jokes about Catan and woodworking, Nick, what are we talking about today?
Well, keeping in with the spooky season, we're recording this in October. Let's take on a particularly spooky topic, difficult airways. And we're going to talk about this topic a couple of different times on the podcast. This is going to be sort of an introductory episode where we talk about what makes a difficult airway difficult, talk about the broad strokes of it. And then we're going to double click on the physiologically difficult airway, which in many ways I think is the more important case for ICU and critical care folks to understand.
I couldn't agree more, Nick. The anatomically difficult airway is definitely a topic we're going to leave alone for another day. And it is admittedly a fun topic to discuss, whether it's awake fiber optic intubations or cricothyrotomy. But frankly, if you have to pick one of the two subtopics to really master, I think having a solid understanding of the physiology of a difficult airway, I think having a solid understanding of the physiologically difficult airway will both serve you well and will likely be more relevant to your day-to-day operations, more so than perhaps mastering the scalpel finger bougie technique of the bedside cricothyrotomy.
Don't get us wrong. It's not that we don't love talking about blood, guts, and procedures on Critical Care Time. We just really do love the deep dives on physiology, and we really think that's not just interesting, but it's also practical. So without further delay, let's talk about what makes an airway difficult, and then move on to understanding the physiologically difficult airway.
All right, Nick, so let's put our money where our mouth is. First off, what is a difficult airway?
That's a great question. My definition is that when a skilled provider finds it difficult to safely intubate a patient, that is a difficult airway. I think there are some people who would argue that maybe we should use the term complex instead of difficult. There's a couple reasons for this. Difficult kind of implies that the person doing it had trouble. It's like, the operator, was the problem, as opposed to saying, no, this is a really challenging situation. Conversely, if I do an airway and I do it quick and I make it, quote, look easy, that doesn't mean it was an easy airway, right? It could still have been very challenging. So maybe this terminology ought to change a little bit. Another thing that we should probably talk about is that anatomy and physiology are patient factors, but there are a lot of other factors beyond the patient that can make an airway complex. The experience of the operator, the experience of the team, the equipment you have available, the environment where you're working, all of those things can take an airway that in one setting might be straightforward and then make it quite difficult. So, even for a anatomically and physiologically straightforward airway, you can imagine if you are a fatigued operator, you're working with an unfamiliar team in a different part of a hospital, you don't have access to the meds and equipment you usually use, that could be very complicated. You know, it's important to remember that human factors complicate many an otherwise straightforward airway. And I can tell you that I, for one, am not at my best when I'm kneeling on the floor of a bathroom intubating somebody who's getting chest compressions while I'm getting soaked in a puddle of what I can only hope is water.
Yeah, I think that's a great discussion to be had for sure, and totally agree that there are a lot of complexities that can make an airway difficult, and perhaps thinking of an airway as being complex rather than difficult, that nomenclature may be better overall. But for the purposes of our discussion and on this episode, we're going to use the term difficult. That's kind of the classically used term, but I think it's important to just remember that concept of complexity and the crucial fact that many factors extrinsic to the patient affect airway management. And one other thing I'll say is that a lot of these factors we can mitigate through things like training, experience, or good team leadership. But the reality is a complex airway is a complex airway. And, those are going to be challenging situations that you just have to be ready to tackle, sometimes without a whole lot of lead time. Kind of with that all laid out, we've already said we're going to kind of break this discussion down into the anatomically difficult versus the physiologically difficult airway. And so I think it's important for us to have an understanding of what those terms mean. So when we talk about an anatomically difficult airway, it's pretty straightforward. I think most people have a good idea as to what that means. It's an airway where the geometry or the physics or the ergonomics, what have you, make it a more difficult airway to secure. So another way you could say that is anatomic characteristics might hinder BVM ventilation. They could hinder visualization of the chords. And then also they could, those anatomic characteristics could inhibit your ability to watch that tube go through the chords and actually, be able to see it. And it's on its way down. Versus physiologically difficult airway, where there are physiologic characteristics that make it difficult to, let's say, induce that patient and safely transition them to positive pressure ventilation.
I think that's a perfect encapsulation of the difference between these. I want to emphasize to our listeners that there are a couple of ways where the physiologically difficult airway can actually be more challenging. So first of all, it's often easier to anticipate an anatomically difficult airway. If you look at their chart, somebody who was difficult to intubate last year is likely going to be difficult to intubate this year if it's for anatomic reasons. Also, we can look at external clues. We can look at mouth opening. How big is their jaw? Is it forward? Is it back? Is there facial hair present? How big is their neck? How mobile is it? Et cetera, et cetera. And we have validated tools and mnemonics like Lemon or Machoka that can help us take these external clues and turn that into some pre-test likelihood of how risky it's going to be. On the other hand, it's much harder to anticipate a physiologically difficult airway because in many cases, you have to know what's going on inside of the person. The factors that make a physiologically difficult airway are dynamic. So somebody might have been a straightforward airway last week or even yesterday, but something has changed about their physiology, and that can make them a extremely physiologically difficult airway today. For example, if they had a PE. The other thing is that the external clues are often subtle or absent. And we don't have such great mnemonics to guide us. Another factor is the skill of the operator can do a lot to mitigate the challenges of an anatomically difficult airway. So for example, right, if you are experienced intubating over a bronchoscope, that skill is very useful to overcome many anatomically difficult airways. But in contrast, being good with my hands won't really help me fix somebody's failing hemodynamics, right? It's a different skill set. And being experienced at dealing with anatomic problems doesn't transfer over to being good at dealing with physiologic problems.
Also, I think back to my training, and we spent a lot of time practicing our intubations in the operating room with anesthesiologists and CRNAs, and you can get kind of comfortable with the workflow in that setting, which is very controlled. And typically these are patients that have been pre-screened, pre-digested. They're not undergoing acute changes in their hemodynamics or acute changes in their physiology that can really make for a pretty sporty experience. So in contrast, intubating patients that are critically ill is very different. they are dynamic. There's perhaps a lot of different comorbidities to contend with that are in varying degrees of decompensation. And so it definitely can make for a much hairier experience. It's funny because a lot of anesthesiologists like to think of the, making the comparison between what they do and aviation. And kind of having those checklists to enhance safety, and that concept is somewhat predicated upon a controlled and fairly predictable environment. One way that you can look at this is, in a sense, OR intubations for elective surgeries are kind of like commercial air travel. It's scheduled, it's routine, and when there are safety concerns, the flight can be delayed, it can be canceled. Similarly, the case can be delayed or canceled. Versus in the emergency department, in the intensive care unit, or even in the pre-hospital setting, it's a lot more like military aviation. And so that kind of strikes a chord with me. You're in these circumstances, the work needs to get done. It's going to be an austere environment. It kind of is what it is. And so you have to be able to scramble and react and adjust fire based on unforeseen circumstances, unforeseen situations, and whatever difficulties you come across. You really can't abort the mission, because aborting the mission in this circumstance means your patient is going to pass away or otherwise suffer some untoward consequences that we would like for them to avoid.
Absolutely. And I think, in order to underlie the reality of the risks associated with ED and ICU intubations, we should talk about kind of what the literature tells us. So the 2021 INTUBE study, which is a perfect acronym, by the way, they looked at almost 3,000 critically ill patients who were undergoing intubation. And they found that a major adverse event, such as hypotension, severe hypotension, hypoxemia, occurred in 45% of those intubations. Cardiac arrest occurred in 3.1% of people in the peri-intubation period in that study. That really is a terrifying number, because in contrast to the commercial aviation routine environment of the OR, where cardiac arrest with induction is a very rare event, that suggests that, serious adverse events happen frequently in the ICU setting, perhaps 1 in 30 intubations. So keep that number in mind and be scared. One of the biggest reasons it's risky to intubate these people is because of the changes in physiology in critical illness. I think that if you get one thing out of this show today, it's if we can impart to you a healthy fear of that and have you remember what those physiologic changes are, I think it will go a long way towards reducing that 3%.
So that was a great introduction into the topic of the difficult or the complex airway. And so now I think it's a good time for us to start honing on the physiology and what we're really going to focus on for the remainder of this episode. So obviously the episode's called the Physiologically Difficult Airway. So we're going to have to talk about physiology here. And we're excited to do that. So in order to open this discussion and kind of understand it a little bit better, let's discuss the physiology that happens in general when we induce someone and then subsequently intubate them. So typically, at least in my experience, the normal sequence of events is that we, first we'll, I guess as an aside, kind of gather our team, talk through the plan, talk through our plan A, plan B, plan C, have all of those ducks in a row. This is a situation where planning is really everything, right? And so whenever you have the opportunity and the presence of mind to set up all your tools, set up all your team, you should absolutely do that. Okay, so we'll go ahead and say that's all been done. And so now, as we look at the normal sequence of events, first we're going to give medications that induce unconsciousness and amnesia. And usually at the same time or slightly thereafter, we're going to give neuromuscular blockers that relax the patient's muscles. And then usually after a short period of apnea, when the medications are in full effect, we're able to see that by kind of trying to stimulate the patient, look for chest rise and fall. If none of that is present, we feel pretty good that we can proceed with airway manipulation in order to visualize the vocal cords, and then we can pass the endotracheal tube through them. Nick, why don't you walk us through these elements of intubation in greater detail?
Yeah, I think that's a perfect setup. So we have to think about kind of 4 key physiologic things that will occur that are all potentially life-threatening. The first is induction agents will do 2 things. One, they'll cause some degree of vasodilation, and they'll also cause some degree of decreased sympathetic tone. And both of those can cause hypotension. You get hypotensive both because your SVR is lower and because your cardiac output is lower. The choice of meds that we use really does matter here, but it's important to realize that even gentler medications can still cause significant hypotension. The reason for this is that patients are often in extremis when we intubate them. So if they're super catecholaminergic, their sympathetic nervous system is ramped up. If we give them meds that make them unconscious, even if they don't directly cause a lot of vasodilation, they're still going to lose that sympathetic tone. And so you should expect to see hypotension if somebody is compensating by being tachycardic and really sympathetically activated. So that's point number one. Induction agents cause vasodilation and loss of sympathetic tone. Point number two is that apneic interval in between when we've given the meds to cause muscle relaxation and when the person is at good intubating conditions. Depending on the meds that you use, that period could be anywhere from, as little as maybe 30 seconds to as long as maybe 90 seconds. But in that period, the person may not be breathing or probably isn't breathing. And that's going to cause them to be hypoxemic and hypercarbic. Both of those are going to cause your pulmonary vasculature to constrict. So your pulmonary vascular resistance will shoot up. And additionally, they're going to be more acidemic, which is going to drop their systemic vascular resistance and drop their cardiac output. And so this can be very significant, especially in somebody who's starting off already with acidosis or hypoxemia. The third effect we should talk about is the effect of airway manipulation itself. So once that apneic interval is over and you've put the laryngoscope into the person's mouth and you're adjusting your view, putting pressure on the mouth is going to trigger a lot of airway reflexes. And even in somebody who is unconscious, there often is some degree of physiologic response to this. So some studies have shown that your systolic blood pressure increases by about 20 millimeters of mercury. And in some cases, your ICP also rises. Usually this effect is about 5 centimeters of water, but in some cases it can be much higher. And so this is a situation where the choice of induction meds really matters. If we can medicate somebody appropriately, we can blunt these effects and hopefully not cause any problems with the increased ICP. The final one, and in many cases, the most important physiologic effect is the effect of transitioning to positive pressure. And in order to understand this, I want you to think about what's going on right now with me. So when I take a deep breath in, my diaphragm moves down, the pressure in my chest becomes negative, and that negative pressure pulls air down into my lungs. But the negative pressure in my chest also has an effect on the blood vessels in my chest. So you can imagine that when the pressure in my chest becomes more negative, it helps pull blood out of the IVC and SVC into my heart. That increases my preload. Now, if I transition to positive pressure, if you put a tube in or if I'm on non-invasive bilevel ventilation, the pressure in my chest is now positive. Now, instead of negative pressure pulling blood into the heart and increasing the effective preload, now you have a situation where that increased pressure in the chest is actually making it harder for blood to get to the heart. So I have decreased preload. So this is a situation that comes up a lot when somebody has hypovolemia or preload dependence, right? Somebody who is doing fine on negative pressure may do very poorly when they transition to positive pressure. And that can be a crucial variable here.
Man, Nick, that was just like a tremendous discussion of physiology as it relates to induction and intubation. So thanks for providing that for our audience. To summarize for our audience, we've covered a ton of really valuable information. There are essentially 4 major physiologic effects of intubation and induction that we kind of went through in great detail, I think. First of which is vasodilation, secondary or related to loss of sympathetic tone due to medications that are given. The second would be that worsening acidosis and hypoxemia that you see during the apneic interval. Of course, if the patient's not oxygenating and not ventilating, then they're going to become hypoxemic and they're going to become acidotic. So not terribly surprising there. We also know that there is a rise in intracranial pressure, and that's often a function of laryngeal manipulation as we're trying to get a view, trying to pass the endotracheal tube. And then finally, there is a decrease in preload that we note whenever a patient is transitioned from standard negative pressure ventilation, i.e. breathing, from a nasal cannula, to positive pressure, whether that is the endotracheal tube or a non-invasive device. And so, kind of based upon all of that, I would say that the old adage, an ounce of prevention is worth a pound of cure, is quite relevant when we're talking about induction and intubation, especially in the ICU, when we're likely to encounter some of these physiologic challenges. And That being said, sometimes it's, of course, easier said than done. It may be, for example, pretty intuitive to start a patient with a low blood pressure on vasopressors, whereas there might be other complications that are more complex, more nuanced, that you may not be ready for upfront. And so it's good to at least recognize that these can occur and have some plans in the back of your mind to deal with these sorts of challenges. And so I think at this point, as we've done in other episodes, it might be a good time to transition over to some cases to try to illustrate some of these challenges and how we handle them. What do you say, Nick?
Absolutely. I think, one of the things we always try to do is teach the theory and then show how it can be applied practically. So let's use some cases as an opportunity to do that. Let's do it.
All right, Nick. So let's start with this one. We've got a 55-year-old patient who has a history of cirrhosis, and he's admitted with a brisk upper GI bleed. He's got a heart rate of 130 to 140. His blood pressures are 80s over 40s. He's tachypnic, but initially his SpO2 is reassuring in the mid-90s on ambient air. You get a point of care hemoglobin. His hemoglobin weighs in at about 5. Up until now, he has not received any blood products. When you see him, he's initially confused, he's a bit somnolent, but then suddenly he becomes unresponsive to sternal rub. His respirations are now sonorous, and he's desatting to the 80s. What are you going to do with this guy? How are you going to manage his airway?
So first off, this is a very real and very scary situation that I call the under-resuscitated intubation, right? This happens all the time, and this is a situation where you have to manage the physiology correctly, or this person will likely die in the peri-intubation period. So first off, let's call out what's happening here. This man is in hemorrhagic shock. He is partially compensating for hypovolemia due to blood loss with his tachycardia, but he may lose this compensation with sedation. Second, and maybe even more important, his preload is already low, and the transition to positive pressure ventilation is going to make his effective preload much, much lower. And then finally, he's already a little bit hypoxemic, probably because he's obstructed and hypoventilating, and because his hemoglobin's low and he's extracting so much oxygen. So there's a lot of factors that put him at risk for a physiologically complex airway. So let me actually ask you, how would you, now that we've talked about the physiology, how would you approach this practically? Like, what would you do in the first 30 seconds?
Yeah, so I think probably in the first 30 seconds, especially in a situation like this, I'd absolutely be calling for help. This is going to be an all hands on deck operation. I'm going to anticipate a physiologically difficult airway for sure, but also there may be some anatomic considerations as well in someone who has cirrhosis and you're worried about the potential for hemetemesis, which could make for a very challenging airway. So definitely all hands on deck. And then next thing we're going to want to do is activate our massive transfusion protocol. So we're going to want someone to get out to the blood bank, grab a couple units of blood. Usually they'll come back in a cooler with those units of blood. And you want to keep that going. Okay, so you want to make sure
this is a run, don't walk situation, by the way.
Exactly right. Yeah, this is not we're not taking our time here. So start with those 2 units. We're going to kind of have a revolving door, if you will, keep getting blood in, potentially use something like a Belmont-like device to deliver that blood more quickly. And of course, if you're going to do that, you're going to want to have good access. And so this is not the time I'm going to drape the patient, put in a triple lumen central line that's a mile long, but rather having some good peripheral IVs would be great. Something like a Cordis or a trialysis line, if that's present for whatever reason, that those are viable options for sure. And then an IO too. Let's not forget about IO access if you need to do that as a means to resuscitate the patient. So either way, we're going to make sure we have good IV access. And then getting over to the airway, which is, of course, what we're talking about here, I think it'd be reasonable to start with a non-rebreather, see how they do with the non-rebreather, potentially put in an OPA with a jaw thrust maybe to try to just optimize their positioning and provide some supplemental oxygen to increase that baseline saturation.
And by the way, I like to think of an OPA as kind of a barometer, too, of how much of a gag reflex they have, right? Not only does it resolve some degree of airway obstruction, but it also kind of tells you if this person is really protecting their airway at all. If somebody tolerates an OPA without gagging, that's usually a sign that they may need more than just the OPA.
That's a great point, Nick. Yeah, for sure. So the OPA kind of has a diagnostic benefit there too. So anyway, get the OPA in place, maybe a jaw thrust, try to optimize their positioning, and hopefully we can get that sat up and also denitrogenate them while keeping the airway patent. So that can all be pretty helpful. Other thing we're going to want to think about. So on the one hand, when you have someone hypotensive, you're going to put them in some head down in Berg, as I like to say. You want to keep the head below the legs, optimize blood flow to the brain. But in this case, we have a high suspicion for blood in the stomach, and so this is a case where we might actually want to flip the paradigm on its head, no pun intended, and have the head up as opposed to down. So we might want to go ahead and have the patient flat, angle the bed up maybe 30 degrees or so, and let gravity help us keep blood in the stomach and not up in the airway. What would you say on that note, Nick?
Yeah, just to amplify that point, this is not a situation where you want the head of the bed up. You don't want to fold the bed and add pressure to the belly. What you want to do is you want to make the bed flat and then tilt the whole bed. That way it's kind of like their feet are down, their heads up. They're going to look like they're sliding almost. And that's going to, without raising the pressure in the abdomen further, that's going to have gravity help you.
That's a perfect point, Nick. Yeah, thanks for clarifying that. And so, while we're talking about blood in the stomach could end up being blood in the airway and could end up being, blood all over the room. So certainly could get messy. We want to make sure we've got 2 suctions that are set up that we know work. Make sure everyone's got appropriate PPE on, especially eye protection, before they're getting in and getting involved with that patient. And so once we've sort of made sure all that's been taken care of, and we're waiting on blood, it may be reasonable to get some crystalloid going. We don't love doing that typically because we worry about dilutional coagulopathy, but really, crystalloid should not be going for very long in a patient like this, especially if you're in, let's say, a bigger hospital with a robust massive transfusion protocol and you're able to get blood to the bedside quickly. So I think in that circumstance, it's reasonable to get some LR going, some lactated ringers, get a few hundred cc's in them just to help support the preload. And then similarly, as we're trying to defend the MAP, getting a vasopressor on like norepinephrine is not a bad idea. And hopefully our audience remembers from our discussion of vasopressors previously that one of the benefits of a vasopressor is you do get some venoconstriction, and that sort of augments your preload by dumping some of that venous blood into the right side of the heart and then onwards. Is that kind of a strategy that you lean on as well, Nick?
Absolutely. Remember that vasopressors are going to increase your preload because of that venoconstriction. And so that's going to be a useful way to temporize this person. I think the key thing to really emphasize to our listeners here is that we want to try to wait to intubate him until we've resuscitated him and fixed the fundamental physiologic derangement, which is hypovolemia due to hemorrhage. If you can stay at the airway, if you can keep his airway patent, you can pre-oxygenate him and take just a few minutes to get some blood product into him. That could be the difference between this being a very risky and a somewhat risky or less risky procedure. One other point that we should probably make is that in any physiologically challenging airway, but especially in a case like this, measuring their blood pressure in real time is really valuable. So let's say that you've bought the airway, but I'm there assisting you as your partner. While you're managing the airway, maybe I should put in an art line real quick. That way we have real-time blood pressure measurements. So it's not like we're waiting every minute for the cuff to cycle and we're reacting to a blood pressure. Instead, we'll be able to see the blood pressure beat by beat. So we'll be much more proactive about managing changes in pressure.
Perfect. I think that's a great little pearl because a lot of times that arterial line ends up being a secondary or tertiary thought. But in cases like this, when you're actively resuscitating a patient and you're staring down the barrel of a tenuous airway, having that beat-to-beat blood pressure monitoring can be super helpful. So another thing, Nick, I'll ask you because I think you have a pretty elegant way of approaching this. So we've talked all around the airway. We haven't really attacked the airway itself yet. So tell me a little bit about your approach to an airway like this. What kind of induction agents are you using? What kind of neuromuscular blockade? Give me the Nick Mark approach to this airway.
All right. Well, I think the key for induction is going to be really gentle hemodynamically. So the 2 drugs that are kind of outstanding for that are ketamine and etomidate. Ketamine, probably the one that I prefer more, probably a little bit more hemodynamically neutral. I think the other thing to emphasize is this is not the situation to give a big slug of propofol. There are some people who would argue that you can give a low dose of propofol, which will be effective in this setting. And while that's true, I think it's hard to do correctly. It's easy to underdose or overdose. So why not use a more hemodynamically stable med like ketamine? Regarding neuromuscular blockers, the two that we often choose from are rock or sucks. I prefer rock to sucks. I almost never use sucks if I can avoid it. Maybe at the end of this episode, the audience can hear my rant on this subject. Talk about why that is. And then in terms of airway mechanics, right? Actually, do you want to kind of speak to this? Talk about like what your approach would be.
Yeah, I think we probably agree on this. So normally we like to use video laryngoscopy, and we're gonna talk about in a subsequent episode, some of the literature behind using video laryngoscopy over direct laryngoscopy in regards to first pass success. But typically we lean on video laryngoscopy because it has the potential to give us a better view. Especially when you have airways that differ from kind of normal anatomic alignment, let's say. The problem with video laryngoscopy in a situation like this is it really doesn't take a lot of blood to completely obscure your view. And so it is often a better choice in these circumstances to use a standard geometry laryngoscope blade that's not a video scope, where you're actually looking, true and true down the barrel of the airway, so to speak, and you don't have to deal with the potential of your camera getting completely obscured by blood. Now, granted, if you're using a standard geometry video laryngoscope with a standard blade, you can generally use that the same as a direct laryngoscope. I find it to be a little bit clunkier than your kind of typical Mac or Miller metallic blade, but you can do that. The bigger issue becomes if you're using a hyperangulated blade, which is really designed for you to rely on the camera, and you completely lose your view, you're pretty much hosed. Does that kind of jive with how you approach these folks, Nick?
Exactly right. I mean, the way I think about it is it takes a whole lot of blood to completely cover my visor or goggles so I can't see. So to degrade my view with direct laryngoscopy is hard, but it only really takes one drop of blood in the wrong place to make the camera on a video scope useless. And so I agree with you. This is a situation where you can use VL, and I like VL, and I use VL almost all the time, but you should use a standard geometry VL blade so that if your camera becomes useless because of a soiled airway, you can then convert to sort of a standard DL approach. You can just raise the jaw more and get your view. I always like to think about this Mitch Hedberg joke that there's no such thing as a broken escalator because a broken escalator becomes stairs. There's no such thing as a broken standard geometry VL blade because it becomes a DL blade.
Very true. Yep, that's kind of my thought on it as well. I still find that I have slightly better visualization with your metallic blade if I'm just doing straight DL, but certainly the ability to use VL by and large is going to save you a lot of time and headache with airways, difficult or not. But then being able to sort of alter your approach with the standard geometry blade in the setting of a soiled airway is super clutch. So we'll definitely cover this in greater detail when we talk about the anatomically difficult airway, which we view as a great partner episode to this one. But just to sort of summarize it, 50,000 foot view, we want to keep the blade high and dry and lead with suction. That's how we're really going to try to approach this patient in terms of getting a blade into the oropharynx.
And it's very useful to have two suction setups in a case like this too, right?
Absolutely.
Sort of Boy Scout motto, one is none, two is one. If one of them fails, you want to have the other one. If one of them gets obstructed, it also means you can do things like you can basically park one suction in the posterior oropharynx and then use another to sort of clean up selectively. So, in a situation where you're expecting a soiled airway, there's a lot of things that you can do to preempt that and to try to limit, the effect on your visualization.
Perfect. Yeah, great point. So at this point, we've got our approach. We're ready to go. Ideally, we've gotten his blood pressure up a little bit as we've been getting the airway ready for us to intubate. And so now we're ready to proceed. So in a case like this, I anticipate he may very well get hypotensive during intubation. And in that situation, I'll bolus fluids or blood and use those push dose pressors to support the MAP.
And this is a situation, by the way, where let's say you and I are doing this case together and you're managing the airway and I'm sort of, leading the resuscitation otherwise. I'll I'll be, saying, hey, let's push 400 of phenylephrine, let's push, 50 mics of epi. But if I'm alone, is often the case with this, right? I'm going to empower my team. If the blood pressure gets low, I want you to push this. That way I don't have to be, thinking about two things at once. That, they can say, okay, blood pressure is low, I'm giving the epi. Okay, blood pressure is still low, I'm giving a second dose of epi. Right? Because you don't want every decision to go through you when it's a, seconds matter, mission critical decision like that.
Excellent. Yeah, that actually dovetails nicely with our discussion, previous episodes about leading a code team and how important it really is to. And this is functionally the same concept, right? I mean, this is a high pressure, high stress, high risk situation where you have multiple players, and making sure you're using that closed loop communication. You've got roles well defined. It's only going to help you in a situation like this. So I'm glad we were able to double tap that.
One other point that I'll make, maybe I should make this later in the episode actually, but I'm just going to say it now because I've started talking. I like to set the monitor so that the pulse ox is making tones and the pitch tells you what the sat is. That way I can have situational awareness to the sats while I'm focused on the airway. I can hear it. I can know if they're desatting. I can tell. I'm not very tonal. I don't have perfect pitch, but I can tell the difference between a sat of 70 and a sat of 90, by the tone.
I do the same thing, Nick. So I think that's a great strategy. So I guess before we move on, I'll go ahead and summarize sort of what we talked about with this very tenuous patient. So really, first off, you're going to fix the fundamental physiologic derangements that we're dealing with. So in this case, it's hypovolemia and hemorrhage. If there's any way for you to delay the intubation for a few minutes until that physiology is corrected, you should do so, because remember, when we push those induction medications, we're going to derange the physiology further. And so it's important to try to get things as stable as possible before you proceed. Make sure that you recognize, of course, giving those induction medications causing vasodilation is going to likely require you to have some fluid boluses ready, blood boluses ready, and those push dose pressors as well. So be ready to utilize those in the setting of worsening blood pressure following induction medication administration. And then the other thing we talked about is sort of the benefits of a standard geometry DL or VL blade in this circumstance in the setting of a soiled airway.
Yep. Standard geometry VL is your friend in a case like this. Excellent. Great summary. So now that we've discussed the under-resuscitated patient, let's move on to a different case. Do you want to present the next one to me?
Sure, yeah. Let's talk about a new case. So we're going to talk about this 31-year-old gentleman with a history of diabetes who's admitted to the hospital with dyspnea. Chest radiograph reveals bilateral lobar pneumonia. His lab work is concerning for DKA with a blood glucose of 700, an anion gap of 26, a serum bicarb of 10, a PCO2 of 15, and a pH of 7.1. So the patient's going to get some prompt empiric antibiotics given the presence of a multifocal pneumonia, crystalloids, and an insulin infusion while in the emergency department. He's going to get sent up to the ICU where he is awake and alert. But after a short period of time, we notice his mental status is starting to wane a little bit. We're seeing some tachypnea, some tachycardia. But at this point in time, at least, he's normotensive. That change in mental status is starting to become more lethargy. And we take a look at the patient and see that he's using accessory muscles to breathe. The nurse who's alongside you says, hey, it looks like he's tiring out. And so, of course, we all hate to hear that. We get a little bit nervous when we hear that. In the setting of that decompensation, we repeat a venous blood gas, and it shows that now his pH is 6.8, his CO2 is up to 45, and a venous lactic acid is 7. So, guy's looking pretty sick, Nick, and it doesn't sound like it's going to be an easy intubation. So, once again, I'll pose the question, how do you approach this guy?
All right, this is another very scary situation that I'll call the acidemic patient, the patient with severe acidosis. This is an extremely dangerous situation to intubate. You have to recognize that initially he was blowing off a lot of CO2. He's blowing his CO2 down to 15 to try to protect his pH. But all that work of breathing is catching up with him. Maybe that's why he's making lactate. Maybe the sepsis is making lactate. But whichever way, now he's got a lactic acidosis on top of a diabetic ketoacidosis. And he is not in a good place. This is somebody who is very high risk to die if we don't intubate him correctly.
Which is unfortunate because that sort of, it stands contrary to the old adage, don't intubate DKA. And it's true that we really don't want to intubate people like this if we can avoid it, but I'm kind of thinking maybe we can't avoid it in this case. Do you want to elaborate on that old adage, Nick?
Yeah, so I think that's right. I mean, in general, right, if somebody has DKA, you can manage that with insulin and crystalloids and treating the underlying cause, and often they recover pretty quickly. And most people can maintain a high minute ventilation for a couple of hours, and they turn around. This is a different situation. This is somebody who is probably in respiratory failure because of pneumonia. That's not going to turn around in a few hours. That's probably going to take days. And he probably can't maintain a respiratory rate of 40 or 50 for 2 days. So fundamentally a different situation. The other thing is that even if that DKA were to turn around, well, there's another acidosis there too, which may not turn around. So this is not your typical it's just DKA situation. This is worse than just DKA. I suppose we should probably talk about kind of why this is so high risk. So we talked about this a little bit before, but remember that this guy's pH is like 6.9, 6.8, we said. And so if he's apneic, even for 20, 30 seconds, his pH is going to drop. And there's a very high likelihood that he will code if that happens. And so what we really, really need to do here is we really need to fix the fundamental physiologic derangement, which is his acidosis. And there's a couple of things that we should think about doing in sequence. First off, just like you said in the last case, we got to call for help. I need respiratory in here ASAP, and I want them to bring non-invasive positive pressure ventilation with them. We'll probably call that BiPAP interchangeably, it's a Band-Aid or a sterile strip. You can use the brand name. You can use the generic name. Anyway, whichever. You guys know I'm talking about the same thing. Just like in the last case, let's throw a non-rebreather on him. Hypoxemia isn't the problem here, at least not yet, but we should optimize everything we can. That will hopefully decrease the likelihood of an arrhythmia if his heart is not irritable from hypoxia. He's also not hypotensive yet. That's probably going to change. And just like in the last case, the transition to positive pressure could be very bad for him. Remember that people with DKA often have glucoseuria. He's probably down several liters. And so we should be ready to give some crystalloid boluses and pressors when that happens. As soon as the BiPAP arrives, I want to kind of be the BiPAP whisperer here. So I want to explain to him what we're doing, tell him we're going to put a mask on your face. It's going to fit tightly. It's going to feel a little weird, but it's going to make it much easier for you to breathe. While I'm doing that, I'm going to ask his nurse to give him some ondansetron. And hopefully we can preempt any nausea. One of the big things you have to worry about with DKA is many of these patients are nauseous, and nausea plus non-invasive positive pressure can get really, really gnarly. And we want to avoid that.
So, Nick, let me just really quickly summarize this first part of this. So, call for help, get some oxygen on them, get respiratory to get that bilevel ready for us so that we can support the patient, recognizing that the classic teaching is, okay, altered mental status, don't put them on bilevel. This is a little bit different than that. This is a case where we're at the bedside, we're using it either to get us out of a hairy situation or bridge us to intubation. So we're not just going to put the bilevel on and walk away. We're going to be there coaching him, as you said. And then, a big part of that is putting it on there, talking him through what you're trying to do, and then also supporting him in other ways, like you mentioned, giving the ondansetron to try to prevent him from, vomiting into the mask and creating a whole mess of a situation.
And it's worth pointing out, too, that we're basically doing a practice run for what's going to happen when he's intubated in terms of the transition to positive pressure, right? Because non-invasive positive pressure will do the same thing physiologically with his preload. Mm-hmm. So this is an opportunity to sort of try that out and see what happens and be ready to manage the physiology of hypotension without the physiology of acidosis and apnea. So we're kind of breaking multiple overlapping problems and we're sort of tackling them one at a time.
Perfect.
I think it's probably worth emphasizing that, DKA is not an indication for BiPAP normally, right? This is not one of the classic situations like heart failure or COPD where this is, clearly indicated by randomized controlled trials. This is a situation where we're using it in kind of an off-label way to fix his physiology, right? His physiology is he's acidemic. His body wants to do Kussmaul respirations to correct that, but he is tiring out and he can't maintain that anymore. So we're going to use positive pressure to help him maintain hyperventilation for a while until we're ready to take over for him. And our goal with this is to get his pH to a safe level so that we can move forward. And ideally, maybe above 7.1, 7.2. Cyrus, do you want to talk a little bit about kind of the settings on the bilevel? We could
Sure.
probably
Yeah.
nerd out a lot on this, but
Yeah, I think we probably can. In the interest of time, I won't take too long to discuss this, but basically, what I'll say in a nutshell is with bi-level, it's similar to ACPC in the sense that you have an inspiratory pressure and an expiratory pressure, which is sort of like the inspiratory pressure and the PEEP. So a lot of times, a standard BiPAP setting might be an expiratory pressure of 4 to 5, an inspiratory pressure of 8 to 10. But the reality is, the bigger that delta is, the difference between that inspiratory pressure and the expiratory pressure, your sort of driving pressure, that's what's really going to help decrease that work of breathing. So the bigger that difference is, typically the more you are supporting that patient, the bigger the tidal volumes are going to be, and the bigger the minute ventilation will be. The other thing that I'll say is this is a case where you want to have a nice high backup rate because that patient might tire out. And so if you need to fall back on that backup rate to maintain your minute ventilation, you want to make sure you're in a position to do so. So perhaps a backup rate like 18 or 20 as opposed to 6 or 8, which is a standard setting. So another thing that I'll mention here too is that you want to make sure you're using the right mode of BiPAP. So a BiPAP ST mode is going to be effective in that it's going to continually give you the same amount of support versus something like AVAPs, which is commonly used in folks with sleep disordered breathing, that is adaptive and varies based upon the patient's effort. In this case, we want to fully support the patient. We don't want them to work hard to breathe and then take away some of their support, causing them to work harder and harder to breathe. For those of you that are into ventilators like we are, a good analogy is comparing AVAPs to PRVC, or pressure regulated volume control. It's basically the same thing, more or less. One is non-invasive, one is invasive. So really, all of that is to say, make sure you've got a good delta P, a good driving pressure to support the patient. Make sure that you're using a BiPAP ST mode as opposed to an AVAPs. And then finally, make sure you've got a good backup rate, something like 18 to 20 as opposed to 6 or 8.
Exactly. That's exactly right. And I think, the key here is we want to help them achieve the Kussmaul ventilation that they were doing when we first met them, when their PCO2 was blown down to 15. We want to get them back there transiently so their pH will come up so we can safely intubate them.
Perfect. So we've talked a lot about the non-invasive support that we can use and kind of got our patients set up for success. What about giving them some bicarb?
Yeah. So it's a great question. So theoretically, in patients with DKA with a low pH, like less than 7, bicarb does have a role. In this case, it's a little bit tricky because he has both a ketoacidosis and a lactic acidosis. And there's this theoretical risk that with a lactic acidosis, if you give bicarb, you can trap the lactic acid intracellularly, where it's going to cause more cellular dysfunction. So you get more smooth muscle dilation, more hypotension, etc. So paradoxically, bicarb and a bad lactic acidosis might theoretically make things worse. The other thing we should mention is that in order for bicarb to raise your pH, it has to turn into CO2. You can imagine like when you drop Alka-Seltzer in water, right? It makes the water more basic. And the way it does that is by bubbling off CO2, right? If you put bicarb into somebody, they need to blow off that CO2 in order for their pH to be raised. So if his minute ventilation is fixed because he's exhausted and he can't breathe much more, bicarb may not be your friend.
So with that being said, are we going to give bicarbonate or not?
Yeah, force me to put my nickel down. So I think theory yields to empiricism. So once he's on BiPAP and we've increased his minute ventilation, let's try pushing some bicarb and see what happens. If his BP comes up, if it seems like he's gotten a little better, maybe he will improve with it. So maybe we give a little bit more. If we put him on BiPAP and we give him some bicarb and it doesn't help, okay, we tried it. We're not going to do any more of that. I think hopefully we can improve his pH enough with the non-invasive ventilator that we may not need bicarb. But in some situations, it's worth trying that as well.
Excellent.
So let me ask you, in the case, have we made any progress in improving his pH?
Well, fortunately, we have. So his pH is now up to 7.2. His PCO2 is down to 12.
Okay. So great. So, our goal is always to fix the fundamental physiologic derangement to make a physiologically dangerous airway safer. We've just done that. To use the aviation analogy, bilevel has kind of given us a little more altitude to work the problem. It's tempting to say, great, we fixed it. But we have to realize that this is still a very precarious situation, right? I mean, he's probably breathing 40 sometimes a minute. He's getting enormous minute ventilation. If he were to take off this BiPAP, he could code within seconds, right, from acidosis. So we haven't solved the problem. We've temporized the problem. Now it's time for us to solve the problem by safely intubating him. Now that we've got a little bit of altitude, then we can do that safely.
Excellent. So being the prescient intensivist that you are, you decide to stay in the room and watch him for a few minutes. Unfortunately, he's now pretty much unresponsive. You repeat a VPG. It shows the pH is about the same at 7.18, but now his lactic acid has risen to 11.
Yeah. So this is not a great situation. I mean, we've made some progress with one problem, but another problem is getting worse. We were hoping we wouldn't have to intubate him because maybe his DKA would turn around, but clearly that's not the situation. So now we really have to figure out how are we going to safely intubate him. Just like in the last case, I want to be really hemodynamically gentle. I'm probably going to reach for ketamine again. Etomidate would be fine too, I suppose. I'm going to use rock in this case. I absolutely would not use succinylcholine in this case because I'm worried about potassium shifts. This is somebody who's probably hyperkalemic from acidosis, and giving them succinylcholine could cause a fatal arrhythmia. I think the key thing to emphasize here is that the big risk is apnea. Even 30 seconds of apnea is going to cause his pH to plummet. So to mitigate that, we need to do two things. Number one, we want to keep the bilevel mask on him until the very last second. This means that we're going to push our induction meds, push our neuromuscular blockers, and then wait, mask on for like a minute until we're at good intubating conditions. We're also going to turn the backup rate up, like as far as it will go, like 34, 35, 36. That way, during this apneic interval, when he's not breathing, the machine is going to breathe for him, right? That way, even after we give neuromuscular blockers, he won't have much of an apneic interval. This is going to be a situation where speed is really of the essence. This is not a good tube for a less experienced operator. The key here is going to be to get it really quick. And so I'm probably going to reach for VL. I always like VL. And what my goal is going to be is basically to have, somebody else get the straps off and just hold the mask on their face. And then when I tell them to pull the mask off quick, I'm going to go in with a scope. I'm going to get my view and put the tube in. Goal is to get it in like 5 seconds. So we had no apneic interval. And then we have just a very, very brief interval from when we took the mask off to get the tube in. And the key to that is to make sure that we're at really good intubating conditions. So we've assured that by using the bilevel machine to keep him ventilated while those meds are circulating and getting to good effect. Once the tube is in and confirmed, now we need to make sure that we resume hyperventilation immediately. Okay? So you get your end tidal trace, you feel good about it. All right, now start hyperventilating him, right? It's very easy for people to sort of default to like squeezing that bag at 12 breaths a minute. Don't let that happen. The person will die. The other thing you need to do is to make sure that you don't default to ventilator settings that are inadequate, right? This is not a situation where you want a rate of 12, 6 cc's per kilo. You want to start with a high rate and a high tidal volume, say a rate of like 34 and a tidal volume of like 8 to 10 cc's per kg. This is maybe going to be too much. That's okay. We can pull it back. We're going to be very aggressive about adjusting the ventilator from here on out. But the key is we know he has acidosis. We want to make sure to hyperventilate him before we intubate him. We want to keep the apneic interval very, very short, get the tube in, and then we want to hyperventilate him right afterwards. Because if we stop hyperventilating him, he's likely to code.
Man, that is a lot of... That's a lot. That's a lot of great information. Hopefully our audience was able to keep up with that. I think this is a really great case that illustrates a very complex, a very physiologically complex airway that requires a lot of thought and a lot of precision in regards to how you approach it. So to summarize some of those great points, the fundamental problem in this circumstance is acidosis. And so we need to try to correct that before we cause an apneic interval that we know is going to add fuel to the fire. This is kind of the same as resuscitating before an intubation. It's just we're kind of resuscitating from a acidosis standpoint and not from a hypovolemia standpoint. Some of the other pearls that you mentioned, Nick, using non-invasive to help assist ventilation with that high backup rate, with the right settings, good driving pressure can be helpful. Every once in a while, it'll help you avoid intubation altogether, but at least it's going to be a bridge to intubation, allow you to do so a little more safely. Kind of in the same vein as that, if you are using non-invasive and you're either thinking it's going to get you out of trouble or get you to that intubation, you want to keep eyes on the patient. You want to make sure you're coaching the patient. And you just don't want to leave the bedside while they're doing that, because a patient could easily, a patient could easily vomit, aspirate, they could become unresponsive on the bilevel. And so you're going to need to be able to act quickly. So stay by that patient. And then again, we're hoping we don't have to intubate, but if you do, definitely lean on that non-invasive as long as possible. Use it during the induction process to help provide you some of that apneic oxygenation. And then be prepared to take that airway as quickly and efficiently as possible. You're going to want to use the tool that you're most comfortable with, the one that's going to increase first pass success, the one that's going to get that tube in as quickly as possible. Recognizing that unsupported apnea is not your friend here. That's going to very quickly lead to decompensation and potentially an arresting patient.
Fantastic summary.
Yeah. All right. So moving on from this case, Nick, do you have another one we can discuss?
Absolutely. So we've talked about hypovolemia, we've talked about acidosis. Now let's talk about hypoxia. So this is a case of a 36-year-old woman who's 22 weeks pregnant. He's admitted with acute hypoxic respiratory failure due to COVID pneumonia. She was initially admitted to the step-down unit, and first on a nasal cannula and then a heated high-flow nasal cannula. But over the last 2 days, she's become progressively more hypoxic. Now her SATs are just 84% on high flow, 40 liters, 100%. While she's in the step-down unit, they quote, they tried CPAP, but she, quote, did not tolerate it. What do you want to do now, Cyrus?
Ooh, yeah. So this is another one that's pretty scary. And it is a classic example of the hypoxemic patient, another person who's at risk for a challenging intubation. Unfortunately, we saw cases like this far too many times during the pandemic. And again, it is really scary. It's also important to recognize that it's also important to recognize that pregnancy introduces some unique physiologic challenges when we're discussing induction and intubation. We're going to cover this in greater detail during an OB emergencies episode that we hope to do in the future. But at least as relating to this case, some of the biggest challenges we think about are decreased reserve of oxygen, both due to increased consumption and due to decreased lung volumes. And then also we know that the gravid abdomen pushes up on the diaphragm, so the FRC, or the functional residual capacity, is decreased. Not to mention that you have changes to the oropharynx and to just the patient's anatomy that granted, that gets over to the other element of what makes an airway difficult, but kind of related to the same situation. So probably worth considering as we're approaching this patient.
Great. Yeah, absolutely. I think recognize that anatomical and physiologic difficulties often run together, and this is a good example of that. I think this is a great opportunity to talk about why pre-oxygenation is so important. So remember that the air that you and I are breathing right now, 21% oxygen, 78% nitrogen, 1-ish% argon for the chemistry nerds out there. If we have somebody breathe 100% oxygen for just a minute or two, or even just take a few full vital capacity breaths, we can change the composition of air in their alveoli from 21% oxygen to 100% oxygen. That means there's 5 times more oxygen available there. And that means that even when somebody is apneic, RBCs that are going through the capillaries in the lungs are going to continue to pick up oxygen. To put this in context, right, your typical person can hold their breath for about 60 to 90 seconds. But if somebody is breathing 100% oxygen, they can hold their breath for more like 5 minutes. And the world record for somebody breathing oxygen, pre-breathing oxygen, is something like 14 minutes.
Yeah, that's a great point, Nick. So in a case like this, I'm going to try to maximize that alveolar O2. I'm going to keep her on the high flow, but I might even add a non-rebreather on top of it to try to provide even more oxygen and prevent any sort of entrainment of ambient air. And so, it would be great to get someone like this on CPAP as well, because you can increase the mean airway pressure. You get that tight fitting mask that can actually really help deliver closer to 100% oxygen. But sometimes that can become challenging too. Sometimes you need to to give medications or otherwise support the patient to get them to actually work with the mask.
Right. I think the other thing too is that sometimes the interface is really the issue, right? So, they tried one mask, they didn't like it. It doesn't mean they won't tolerate all other masks. And so, as a quick aside here, the sort of standard mask that we use with most CPAP and BiPAP in the hospital is it kind of looks like an upward pointed triangle. It goes over the bridge of the nose, it goes down over your face. That puts a lot of pressure on the bridge of your nose. It feels very tight and claustrophobic. A lot of people don't like that. There's something called a full face mask, which looks kind of like what a firefighter might wear. It's like a triangle that points down. It goes above your eyes. It's tight on your forehead and down over your face. That's a lot more comfortable for some people. And then finally, in some places, we have these helmet masks, which kind of, to use the analogy, looks kind of like an Apollo astronaut, like those big bubble, like fishbowl helmets. And this doesn't put pressure anywhere on the face. And so sometimes the key is using meds as anxiolytics, and sometimes the key is trying a different interface. But in many cases, people who quote, don't tolerate CPAP or BiPAP actually will tolerate it if you try the right interface after talking to them, calming them down, and giving them some meds. So let's not give up on CPAP in this lady.
Totally agree. So I wouldn't just accept that this patient doesn't tolerate CPAP. I would kind of try to do some troubleshooting, maybe get an anxiolytic on board. So even in pregnancy, a medication like dexmedetomidine could be helpful. So I might start that, mess with the mask interfaces, try to find something that she's comfortable with. If the dexmedetomidine isn't cutting it, you can even try a little bit of ketamine, low-dose ketamine, just to see if that can break the cycle of anxiety that begets air hunger, that begets more anxiety, et cetera, et cetera. So the goal is really to use these different strategies to get her comfortable and get her using the CPAP mask effectively.
All right. And let's say that you give her some Precedex, you manage to get her comfortable with a full face mask, and her sats come up with that higher FiO2 and with that higher mean airway pressure. Her sats are now back up in the mid to high 90s. So my question is, do you still have to intubate her?
Yeah, it's a good question. If I had a crystal ball, I could tell you. But, the hope is that you don't. But the reality is she's really not out of the woods yet. And so while we fixed the fundamental physiologic flaw here, i.e. a hypoxemia, by increasing the FiO2 and the mean airway pressure, this patient is still at high risk for having a further decompensation and needing to be intubated.
Yeah, I think it's important to emphasize that non-invasive positive pressure works really well for conditions that are acutely reversible. Think about somebody with heart failure where you give them Lasix, or somebody with COPD where they get antibiotics and steroids, right? That can turn around in hours. That's not the situation here. This is somebody who's developing ARDS due to a viral pneumonia. This is probably going to take several days or maybe even weeks to resolve. So it's unlikely that this person is going to tolerate being on CPAP for that long, right? This is probably something that's bought us time. Maybe if we're lucky, we can avoid intubation, but probably we've just kicked the can down the road a little bit. To move the case along, let's just say that her SpO2 does better for the next 24 hours or so, but then it starts to get worse again. Now she's back in the high 80s despite tolerating positive pressure ventilation. She looks uncomfortable. She's using accessory muscles. What now? How are you going to approach this intubation?
Yeah, so at this point, the writing's on the wall. She's going to need to be intubated. And so like in prior cases, it's going to be, measure twice, cut once, if you will. So we're going to prepare, and then we're going to act. A big part of that is coordination with the team, getting our OB colleagues on board, making sure they know what's going on. So we're at 22 weeks, so they may not want to be present to monitor, the fetus. But consider if this is a patient who's further along in their pregnancy, they might want to have some fetal monitoring actively on the patient that they're going to be watching like hawks. So that's a consideration. And then moving on from there, just like in the DKA case, we want to lean on our non-invasive positive pressure ventilation to pre-oxygenate and to maintain ventilation after induction. Because that's going to really help us buy time and also give us the best chance at a smooth intubation. And the other thing I'll mention in this case, again, we're kind of finding as we go through these cases, it's sometimes difficult to tease apart the physiology and the anatomy. This is a similar case. So there are some important physiologic challenges in pregnancy and some anatomic ones too. So we know that the vocal cords of the upper airways are often edematous due to fluid retention, especially if a patient's been in the hospital for a few days. So you might want to consider having a smaller endotracheal tube ready to go, like a 6O or something like that. Patients also often have some weight gain during pregnancy, and so they can even have some kind of increased redundant tissue in the oropharynx that's not related to edema, just related to changes in pregnancy. So that's another thing to consider. And then we know that these folks are at high risk for aspiration. So the gravid uterus, increased abdominal pressure, can increase the risk for aspiration in patients like this. And so you're going to want to have one, if not two suction canisters ready, hooked up, ready to go. And this might be another case, just like in our first situation, where you're going to want the head of the bed elevated, maybe as much as 40 degrees. And ideally, you're not going to want the patient to be bent, but rather have them in that ramped position so that you're offloading that gravid uterus from the stomach, giving you the best chance of a successful intubation.
In the OR, they often have these foam wedge pillows, these giant wedge pillows that you can put underneath to do this. We can do this in OR beds, in ICU beds, just by tilting them, basically tilt them until the person starts to slide down and then go back 1 degree. And that's it.
Yes.
Basically as steep an angle as you can do. And that will, again, use gravity, pull that gravid uterus down, try to keep the contents of the stomach in the stomach.
Perfect point. Yeah. So definitely a good situation to optimize positioning and perhaps use your video laryngoscope along with a bougie in case you're dealing with a tight airway.
All right. So let's say that with that plan, you position her, you pre-oxygenate her, you keep the non-invasive on, just like in the last case. So she doesn't really desat. And then you're quick about it, so she doesn't have much time to desat. Using that plan, you successfully intubate her. And then just to wrap up the case, we'll say she remains intubated for about a week. And then she's really improved. She's extubated. She makes a complete recovery. She goes on to deliver a healthy term infant. And because this is a fictional case, we'll just say that she names it after you.
Oh, that's so sweet. Cyrus Jr. So we've gone through 3 cases now. We've covered a lot of great physiology. Let's try to get through a couple more, shall we?
Do it.
All right. So now we've got a 42-year-old male from the emergency department coming in with PE. He's got RV strain on echo, as well as elevated cardiac biomarkers. His heart rate on admission is 112 with a blood pressure of 120/74. Of note, this patient has a prior history of hypertension and they're on double therapy. But patient didn't take their medications in the last few days for whatever reason. You get a little bit more history, and he's actually been recovering from recent lower extremity surgery that's left him relatively immobile. So you astutely diagnose this patient with a high-risk submassive PE per ERS-ESC nomenclature, and you admit them to the ICU on a heparin drip for close monitoring. You are getting ready to go home. Everything seems to be going well, but you get a call shortly thereafter. The patient is now hypotensive to 80/40 despite initiating norepinephrine, and he's showing signs of respiratory distress. Nick, how would you navigate this minefield?
So this is indeed a minefield. This is a scary situation. This is one of the scariest situations. This is somebody, who's critically ill. They have a pulmonary embolism that's causing them to be in shock. And this has gone from a high-risk submassive to now massive because they are in shock. And so, we'll talk about this in a future episode as well, the topic of managing sick patients with PE. But one of the tenets of that, just like DKA, is try to avoid intubation if at all possible. Why? Well, because the underlying pathophysiology and the effects of meds that we use are going to make things worse, right? Remember that in acute RV failure, they're dependent on preload, and we're going to make that go away. And also remember that the issue here is that they have an increased pulmonary pressure because they have increased pulmonary resistance. And when you make somebody get hypoxic, when you make somebody get acidemic, their PA pressures shoot up. And that can cause somebody whose RV is tenuous to fail completely. And when that RV fails, not only is it going to do a poor job pumping, but it's going to put pressure across the septum onto the LV, and now the LV is going to have trouble pumping. So this is somebody who can get really, really sick really fast. And this is somebody where if you don't correct their physiology as you intubate them, it would be very easy for them to develop RV failure and code. So there's a couple of things we should talk about here. Just remember, first of all, that the physiology here is a perfect storm. There's increased afterload, there's decreased contractility, and there's decreased preload, which is all gonna conspire to kill this person. So the key thing is going to be to do all of the things we've talked about, put all those physiologic ideas together to save this person.
Perfect. So, Nick, I'm glad we were able to get through some of those challenges with a patient like this right at the outset. before we really get into the nuts and bolts, we'll say that this patient was placed on nasal cannula, and it looks like they're struggling to breathe and not doing so well. Do you think there might be a role for non-invasive positive pressure ventilation in a patient like this?
I think there could be. This is a situation where it might buy us time. Hyperventilating them will prevent acidosis. It will potentially shorten the apneic interval. And the other good thing about it is it's going to, prevent their pulmonary vascular resistance from rising due to acidosis. So I think it's a good idea. This is a situation where potentially we might want to combine that with inhaled vasodilators, either inhaled epoprostenol or inhaled nitric oxide. The idea there is that that's going to dilate the ventilated areas of the lung and lower the PA pressures. It's going to improve oxygenation. It's also going to reduce the afterload that this poor struggling RV is working against.
Fantastic. Great points all around. So let's say we get this patient on some non-invasive, we get a good driving pressure going, we have our respiratory therapist set up the inhaled epoprostenol, and you're feeling pretty good about it. But you get a gas shows that the patient's acidotic, hypercapnic, and hypoxemic with a lactate that has risen sharply since the last check about 6 hours ago. It ain't looking too hot, Nick.
No, it's not. I mean, so there's another thing we can try, which is maybe this person is hypovolemic, maybe they have inadequate preload to the RV. So we can assess their volume status, again, a topic for a future episode, and potentially give them a little bit of volume. But, you got to be careful. It's easy to go too much there. Generally, these patients with shock due to pulmonary embolism need a little bit, but not too much. You want to give them enough without going over. We can also think about push dose pressors. This is a situation where you actually want to pick your pressor pretty carefully. Probably don't want to use phenylephrine in this case. Vasopressin might be better because it doesn't affect the pulmonary vascular resistance much. Epinephrine might be better because it will have some inotropic effects to offset a small increase in PVR. Whichever one we choose, I think we want to be mindful about not giving too much either, because increasing systemic afterload is also going to cause problems. So small doses of push dose pressors, small test dose of fluid, not too much of either.
Excellent. Yeah, great points. I think I'll foot stomp a little on the vasopressin just because I think it's a great option. It's a really elegant choice in this circumstance. It's limited by titratability. So, you can do push dose vasopressin. You can give, a half unit, a unit, even up to 2 units in a real pinch if this patient's about to arrest. But putting them on a vasopressin drip isn't a bad idea. It's just you don't have a lot of room to go. The nice benefit, though, is, of course, you get that peripheral vasoconstriction with actually some pulmonary vasodilation. So it seems like the perfect agent. If you combine that with airway support, you combine that with inhaled EPO or some inhaled nitric oxide, you might actually be able to turn the tides in this battle.
Yeah, I think that's a great summary. So how would you approach the mechanics of intubating this patient now that we've talked about how we're going to prepare for it? What meds do you want to give? What tools are you going to reach for?
Yeah, absolutely. So I think this is a case where you're going to want to go with the tool you're most comfortable with. So in a pinch, I like direct laryngoscopy because for me, the geometry is a bit more intuitive and it facilitates a faster intubation. But as we've said before, if you have a video laryngoscope with a standard geometry blade, it sort of like takes that element out of the equation for the most part. So whatever you're most comfortable with in a situation like this is, I think, what you should go with. As far as the actual induction medications, so I'm actually a big ketofol guy. And so what that essentially is like a 0.5 mg per kg of ketamine and a 0.5 mg per kg of propofol. I like that because it gets the patient pretty nicely sedated. You get that benefit of the heavier sedation with propofol, but because you're giving a lower dose of propofol and you're actually augmenting it with something that causes some release of endogenous catecholamines, ketamine, you actually get a really nice, I think, finished product when you use those medications in unison. So that's usually my approach, although just using ketamine or even etomidate might be a reasonable option. I think, Nick, like you, I don't use a lot of etomidate, especially in the medical ICU, as it's grown out of favor with a lot of us with the mounting evidence in regards to adrenal insuppression that can cause problems down the road. And then there are other things that you can do. Some people really like to do awake fiber optic intubations, but I wonder if maybe that's not the best choice for something like this, a case like this. What do you think, Nick?
Yeah, it's a good question. I mean, the advantage of a wake fiber optic is you can essentially have the person be breathing up until the tube is in. So it's another strategy to avoid an apneic interval. It's also a nice strategy because it makes you very, very confident that you're going to get the tube before you've committed to it by giving meds. So there are great things about that strategy, especially if you're somebody who's done a lot of bronchoscopies and you're good at topicalizing the airway and you're good at using a scope. This is a reasonable approach to think about. There's a couple big disadvantages to emphasize in this case, though. First off, it takes time to set up, right? It's another piece of equipment. You got to prepare that. Second, this person has gotten a bunch of heparin, presumably, because they're treating them for a PE. And I'm always nervous for somebody who's therapeutically anticoagulated if I'm going through the nose with a bronchoscope, because it's very easy to add another problem, which is big time epistaxis. You know, do you do it here? Do you not? I think this is kind of, depends on your comfort and your experience. Definitely, if you commit to intubate somebody by giving them paralytics, you better get that tube and you better get it quick. If you want to be more cautious and go with fiber optics, that's one approach, but recognize that you could cause different problems there too, potentially. So, it depends on your experience, your team's experience, and kind of your gestalt with the patient. We could probably talk endlessly about awake fiber optic when we do our episode on the anatomically difficult airway. So listeners, expect more conversation about this in the future.
Okay, fair enough. So I suppose we can save the awake fiber optic intubation for another day. We can talk about that when we discuss anatomy. And, we do have another case that we want to get to. But before we do that, I think it might be reasonable to summarize the pearls from this RV failure case and see if there's anything else you'd want to add. So Nick, do you want to give us a quick summary of what we discussed?
Yeah.
Here?
So I think, the approach of supporting the patient non-invasively first, trying to improve their oxygenation as much as possible, trying to make sure that they're not hypoventilating and that there's no hypercarbia or acidosis, which is going to cause increased PVR. That's number one. I think we have to be thoughtful about our choice of vasopressors. Specifically, vasopressin is a good choice. Phenylephrine is a bad choice. We should be thoughtful about inhaled vasodilators, because they can also help us with this problem. And then I think it's important to be sort of thoughtful about what our approach is going to be so that we have the patient optimized. We've corrected as much of those physiologic problems as we can before putting the tube in. This is not a situation you want to run into. This is a situation you want to try to optimize everything you can before committing to that tube.
Outstanding, Nick. Thank you for that summary. I think that's a great way to conclude that discussion and maybe move on to our last case.
All right, one more, and this would be a quicker case. So, Cyrus, you're caring for a 65-year-old man admitted to the hospital with a traumatic brain injury. He was doing initially pretty well, but he's become pretty much unresponsive over the last half hour or so. You want to get a head CT scan to evaluate what's going on, but he's not really protecting his airway enough. His respirations are irregular. You do a jaw thrust, you insert an OPA, doesn't gag on it at all. His SATs are in the 90s on just 2 liters by cannula once you're doing the jaw thrust. His BP is 180/60 and his heart rate is 42. So first off, what do you think is going on here, and how would you manage this airway?
Man, yes, this is really quite spooky indeed. So we have another physiologically scary intubation, the high ICP airway, if you will. So it sounds like this gentleman is developing a bit of a Cushing's reflex, which is the triad of systolic hypertension, bradycardia, and irregular respirations. And so we obviously need to protect his airway, but there are kind of a couple concerning elements here that we need to tease through. Of course, hypotension can be very dangerous in people with brain injury because the brain's ability to auto-regulate is likely impaired. That's one consideration. We also know that in order to intubate someone, we need to stimulate their larynx, and that can cause an acute increase in blood pressure and ICP. And that could be very bad in a patient like this. So really, we're trying to be as hemodynamically neutral as possible to avoid those big swings in blood pressure. And so in someone like this, I might even give some fentanyl as a pre-medication strategy to avoid that big bump in systolic blood pressure and ICP. And this could be a case where you'll consider propofol too, especially if there's systolic hypertension. The trick with propofol, the problem with propofol is you can easily overdo it. So you could go with my favorite ketofol approach. You could go with etomidate for a hemodynamically neutral, more neutral approach. Or frankly, you could just use ketamine monotherapy. I mean, that's done too. I've done that myself.
Whoa! Wait a second. Isn't ketamine contraindicated in head injury? Haven't we all heard that?
We have all heard it, but interestingly enough, it's not really contraindicated anymore. So the literature suggests that the increases in ICP with ketamine that were noted in the 1970s aren't that literature is not really robust. And there was a more recent study in 2016 looking at almost 1,000 adult trauma patients who underwent RSI with either etomidate or ketamine, and there was no difference in mortality or other patient-centered outcomes between those two induction agents. And in fact, ACEP's latest guidelines say that ketamine is not contraindicated in TBI. So I say if that's what you want to use, then there doesn't seem to be a reason not to.
Perfect. Myth busted. I love it. Okay. Next question. Are you going to use rocuronium or succinylcholine in this case?
Yeah, so I'm almost always a rock person. I usually use rocuronium. But there may be a reason to use succinylcholine because it's shorter acting and you get that neurologic exam a little bit faster. What do you think, Nick?
Yeah, I think that's a really good point. Maybe now's a good time for my rant.
All right. Yeah, go for it, buddy. I know I can't hold you back.
All right, so let me steel man the argument of people who like using sucks first. So there's a couple reasons they like it. One, it's short onset. This means that you get to those good intubating conditions faster, say 45 to 60 seconds instead of the 90 seconds that they quote with rock. This means that there's maybe a shorter apneic interval. The other thing that people really like about sucks is that it has a shorter duration. It lasts about 8 to 10 minutes compared to 30-ish minutes with rock. That means that you can do that neurologic exam sooner. So if there's been a change in neuro exam, obviously you want to be able to change in status. You want to be able to do a neuro exam, right? They also often point out that patients are more likely to have awareness under paralysis when you use a longer acting neuromuscular blocker. So those are all the arguments that you will hear sucks fans make. But I want to emphasize the downsides. All right. So first off, sucks is depolarizing. That means you get big potassium shifts. This can be fatal in patients who have renal failure, rhabdo, burns, acidosis, hyperkalemia, on certain meds, etc. And the problem is that we don't always know that somebody has these risk factors when we are emergently intubating them. So you run a risk when you push sucks if you don't know this person's history very well that you will cause a fatal arrhythmia. Second, fasciculations, right? With this a depolarizing drug, succinylcholine is, those fasciculations consume oxygen. So this means that even though you may get to good intubating conditions sooner, you're using oxygen much, much faster. So it may actually not be better in terms of hypoxia. Normally, we operate under the assumption that shorter time to onset means less hypoxia. But if you're using more oxygen in that time, it may be more of a wash. I would also argue that those advantages that people point to for sucks are not really true. The studies that said that sucks is faster than rock compared high dose of sucks to a low dose of rock, just 0.6 mg per kg. Several studies, including a big one in JAMA, show that higher dose rock, 1.2 mg per kg, is just as fast as sucks with onset in 45 to 60 seconds. Plus, rock is non-depolarizing, so it may be better in terms of preventing DSATs. Second, if you are worried about awareness under paralysis, then you should give this person sedation and analgesia, right? You shouldn't just use a short-acting drug and walk away. You should start sedation so that they are not suffering and in pain. So treat the actual problem. Don't use a bad drug because you are not going to adequately sedate them and treat their pain. Use the best drug and treat their anxiety and pain. The last point. So yes, the duration of rocuronium is longer. And like you, a neurocritical care intubation is a situation where I might use sucks if I feel like it's safe, if I know the person well. But I really want to make one more point, which is I want to introduce you to my friend Sugamidex. Sugamidex is an antidote that can reverse rock. The anesthesiologists do this all the time. So if you are in a situation where you have to intubate somebody with rock because sucks is contraindicated, remember that you can reverse rock once they're safely intubated with Sugamidex. So you don't have to wait 30, 45 minutes for the drug to wear off. You only have to wait until pharmacy brings you the antidote and you give it. So I think, I'm not going to say that I never use sucks, but I seldom use sucks. And I think the reason is because it has safety concerns and because rock is equivalent or better in almost every respect. All right. That's the rant.
Well, that's that was quite the rant, and you don't have to convince me because I was going to use rocuronium anyway. So,
all right, well there you go. If we need to do a neuro exam, we can reverse it. I think that's totally reasonable. All right.
Agreed.
So, Cyrus, are you going to use VL or DL for this case? No reason to think this is going to be a hard intubation. You look at the person, their, mouth, chin, neck, facial hair, nothing about it makes you nervous. Why not use this as an opportunity to practice those old DL skills?
So again, I'll caveat this by saying if DL is your go-to and you are just a DL stud and that's how you get the airways, then that's great. But this is a situation where video laryngoscopy can be helpful for a very particular reason. So the nice thing with VL is that instead of exerting a lot of pressure on the larynx with the standard laryngoscope, where you really need to raise the jaw, video laryngoscopy lets you get that view with minimal force applied. And so in terms of hemodynamics, the combination of pre-medication and VL will hopefully reduce the acute increase in blood pressure. And of course, and we've already discussed why that is helpful in a patient like this. And so, the other thing I'll say from a hemodynamic standpoint, unrelated to the airway, is that we do want to anticipate hypotension, just like in any intubation. So make sure you have, the ability to bolus fluids, the ability to deliver pressors, both push and hanging. As an aside, I'll often just start a low dose of something like Levophed or norepinephrine in pretty much any intubation, just to have it running. Just want the line kind of primed, ready to go. You can always just really easily kind of titrate up or titrate down.
Exactly. And psychologically, there's much more of a barrier to starting a med than there is to titrating a med. So, norepinephrine running at the lowest possible dose, people can titrate that up quickly, but the cognitive load of saying, should I start this or not, will often take longer. So I completely agree with that.
Awesome.
I'll say that with this strategy, you pre-medicate with some fentanyl to avoid a rise in pressure. You give him, let's say ketamine, maybe some propofol too, to induce him. You give him rocuronium. And then you're very, very gentle with the video laryngoscope. You get a great view. You pass the tube quickly. And so you manage to safely intubate him without any major swings in blood pressure. His ICP doesn't shoot up. So nice work. You saved another one. This is probably a good point to summarize the key points in this episode, which are: remember the physiologic challenges of intubation. Remember that when you give meds, it causes vasodilation and loss of sympathetic tone. Remember that when the person is apneic, their acidosis and hypoxia get worse. Remember that when you stick something in their mouth, it often causes their ICP to rise. And then remember that when you transition somebody from negative pressure to positive pressure, it reduces their preload and it can cause them to become hypotensive.
And in order to illustrate these points, we just talked through 5 very scary cases. The under-resuscitated patient, where the key there was restoring volume before transitioning to positive pressure. We talked about the acidemic patient, where the key there was normalizing the pH and avoiding the aptic interval. We discussed the hypoxic patient, where we really needed to make sure we pre-oxygenated effectively with both a high FiO2, but also a higher mean airway pressure. We then moved on to discuss the patient with RV failure, where really everything needed to happen correctly. We needed to do everything right, make sure that we didn't increase PVR more than it already had been increased in the setting of PE. We didn't want to decrease preload too much, and we didn't want to cause too much myocardial depression from the medications given. So definitely from a physiology standpoint, a really complicated situation and something that we all are always a bit scared of. And then finally, we did talk about the brain injured patient. And in that particular population, the key was avoiding swings in MAP and a rise in ICP. And we went through some strategies to do that.
And with that, we've come to the part of the show where we like to say thanks. Thanks to all of the people who have left us reviews, comments, or given us a shout out. We really appreciate your kind words, suggestions, and feedback. Please keep it coming. If you enjoyed our show, please subscribe, give us a like, throw us a 5-star review. This really helps us expand our audience and helps people find us. If you want to give us feedback, tweet at us at CritCareTime, or you could find us individually, Nick M. Mark or Askins_Razor. You could follow us on Instagram, Threads, all the places. You can also find us on YouTube if you want to watch us.
We'd also like to say a big thanks to our sponsor, C-Star Medical. We are fortunate and grateful that this episode and all episodes in Season 1 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more, and that is SEASTARMEDICAL.com.
Before we go, we want to thank all members of our team, our production company, Kurt Belknap for composing our awesome theme. I want to remind you that all of the media, including the graphics, the audio, it's all property of Critical Care Time. That doesn't mean you can't share it. Just say where you got it from.
And finally, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thank you so much for listening to this haymaker of an episode. I am Dr. Cyrus Askin. Have a great night.
And I'm Dr. Mark. Take care, everybody.